All right, good afternoon, everyone. It is 1 o'clock, and so I do want to be respectful of everyone's time. So we will go ahead and get started with today's webinar. So welcome, and thank you for joining today's local partner Title XIX training webinar, which is being hosted by the California Department of Health in partnership with our colleagues at the California Department of Public Health. Um, my name is Erica Holmes, and I am the chief over the benefits division here at the department. And my team is responsible for Medi-Cal's Title XIX claiming policy as it pertains to the interagency agreements that are maintained between our department, DHCS, and CDPH for purposes of the maternal, child, and adolescent health programs. Next slide, please. So today's training is intended to provide additional guidance and clarification to local and county partners around Title XIX funds. And we will cover the specific topics that are listed on this slide. And at the end of today's training, there will also be an opportunity for participants to ask additional questions. I do want to highlight that today's presentation on Title XIX claiming is limited to MCAH and other programs that are covered pursuant to the contract between DHCS and CDPH. This training is not intended to be used for other purposes such as county-based Medi-Cal administrative activities or CMA, or targeted case management or TCM. Information on those programs is available and linked on our Title XIX Toolkit website for your convenience. With that, I do want to quickly pass it over to my colleague, Jim Elliott, to walk us through logistics and reminders for today's meeting to ensure it is as helpful as possible for both our participants listening live today, as well as those who will access the recording at a later date. Jim?
Very much, Erica. Just a quick reminder, especially to some people may be joining, is that this meeting is being recorded and will be posted on our Title XIX Toolkit webpage. If you do not wish to participate in a recorded webinar, then you would need to disconnect. For the courtesy of all of our attendees, please keep your microphones on mute. Later at the end of the session, we have questions. We'll have you raise your hands, and then we will get to you in an orderly fashion. In addition, if you have questions during the meeting, you could add them to the chat feature, and we will be doing our best to answer them as the meeting is going on. And then we will also get to chat questions at the end of the meeting.
Yeah.
Let me see. So, like I said, we'll just be doing the virtual hand thing. We may not be able to answer all of your questions today, but we will be taking note and we will view in the chat. And so we will add some follow-up questions to the FAQ after the end of the next week. And now I'd like to turn it back over to Erica.
Thanks, Jim. So next slide, please. So I just want to quickly highlight today's presenters who you will be hearing speak. They're listed on this slide, and they include myself, Jim Elliott, who you just heard from, who's a branch chief here in the benefits division, as well as Molly Veronini, who you will hear from later today, and who is a unit chief here in the benefits division. Next slide, please. So with that, let's get into the substantive material for today's Title XIX training, starting with an overview of federal financial participation, or as I will refer to it as FFP. So DHCS is the single state agency for purposes of California's Medicaid program, which you all know as Medi-Cal, and we are responsible for ensuring that both ourselves as well as all of our contracted partners, such as those of you on today's call, maintain compliance with all applicable federal and state statutes and regulations around Title XIX claiming, which allows us to flow federal matching funds to contracted partners for services that are provided to Medi-Cal members or for services that help bring additional individuals into the Medi-Cal program. Next slide, please. When it comes to FFP, it's important to understand the various roles and responsibilities of DHCS versus CDPH. As I already mentioned, DHCS oversees Medi-Cal. We also oversee the contract with CDPH for delivery of services to Medi-Cal members, or again, supports that bring additional members into the Medi-Cal program. DHCS also reviews and approves all invoices received from CDPH, which includes those from our local partners with cost information for which federal matching funds are being requested. CDPH is also the entity that directly contracts with you all, and DHCS, in partnership with CDPH, is jointly responsible for ensuring that local partners are submitting information for Title XIX claiming that aligns with CDPH policy and processes, as well as the federal and state statutory and regulatory requirements. Next slide, please. Federal statute and regulatory requirements around FFP come from several sources, including Section 1903A of the Social Security Act, as well as Title 42 of the Code of Federal Regulations. This information, that information is on this slide for your reference. Next slide, please. When it comes to FFP, it's just important to note that we work here directly with our federal partners at the Centers for Medicare and Medicaid Services, also known as CMS. For most administrative activities, CMS is going to reimburse the state at what's called a non-enhanced matching rate, which is 50%, which means that the state has to put up the non-federal share also at 50%. For some skilled professional medical personnel, or SPMP activities, CMS will actually reimburse us at an enhanced matching rate of 75%. Next slide, please. As I previously mentioned, FFP is available for two primary purposes: assisting Medi-Cal members with accessing Medi-Cal covered benefits and services, as well as helping individuals enroll into the Medi-Cal program. Depending on the nature of the local program, FFP may be available for all activities or only a sub-portion of activities. Next slide, please. This slide reiterates much of what I've already shared, so I won't read it all to you, but what I do want to highlight on this slide is that FFP can be available for personnel that are employed either directly by local partners or with subcontracted entities, so long as the activities being claimed are tied to the two primary purposes that I mentioned on the last slide, and the activities are not duplicative. Next slide, please. So let's pivot for a moment and talk about skilled professional medical personnel, or SPMP. The easiest way to think about FFP is as follows. Assuming your personnel are conducting activities that are eligible for FFP, the general rule is that local partners are going to receive a 50% non-enhanced matching rate. To get the 75% enhanced rate, local partners must meet a higher bar. Under federal regulations, enhanced claiming is only allowed for either 1. SPMP staff who have professional education and experience in the field of medical care or appropriate medical practice, with a particular emphasis there on that clinical expertise, or 2. Staff who are directly supporting the work of SPMP staff. Next slide, please. Relative to the professional training and education requirement, please note that this is a 2-year or longer program that leads to a degree or certification. It must also be in a medically related profession. For example, this can be demonstrated by having an active medical license issued by the Medical Board of California. It also could be demonstrated by having a degree in a medical field issued by a California university. Next slide, please. Well, DHCS recognizes that there are some medically related professions that have programs shorter than 2 years, or that may include post-degree or on-the-job training. DHCS unfortunately does not have flexibility in this space, as the professional education and training requirement is a federal requirement and explicit. Next slide, please. Another important factor here to consider is that SPMP staff activities for which local partners are looking to claim federal matching funds must require the use of that SPMP staff's professional medical knowledge, training, and/or expertise. So, for example, if an SPMP staff is delivering training to other clinical staff at a local agency on clinical best practices and generally accepted standards of care for treating diabetes, this would qualify for federal matching funds. However, if that same SPMP staff was managing an office supply contract, this would not count because it does not require use of their medical knowledge, training, and/or expertise. Regarding staff who directly report to SPMP staff, this can include classifications such as, next slide, please. Actually, no, sorry, one back. There you go. This can include classifications such as those listed on this slide, which are secretarial, stenographic, and copying personnel, as well as record clerks who provide clerical services that are directly necessary for the completion of the SPMP staff's responsibilities. I do want to emphasize here the direct linkage required in that supporting staff services, again, must be directly necessary for the completion of the SPMP staff's responsibilities. Additionally, the SPMP staff must directly supervise the supporting staff and their performance. So the staff cannot report to someone else from an organizational perspective and then be casually utilized by the SPMP staff. Lastly, there also must be a documented employee-employer relationship. This requirement is satisfied through the signed agency information form, which includes a detailed duty statement and organizational chart, and an SPMP attestation that each local partner must have on file with CDPH. Ultimately, the employer-employee relationship involves an analysis and assessment of what local partners are doing and what expenses they are claiming for both non-SPMP and SPMP staff working on MCH programs. And as always, I want to reiterate that local partners should maintain appropriate supporting documentation of the employer-employee relationship and make that available to both CDPH and DHCS upon request in the event of either a state or federal audit. Next slide, please. So now let's pivot slightly and talk about how local partners should be approaching how to analyze whether or not something is eligible for enhanced claiming. As a starting point, it might be helpful to clearly articulate some examples of what would not be considered SPMP classifications, which are outlined on this slide. Essentially, these would largely be non-medical health professionals, individuals who have a master's degree in social work but are not licensed clinical social workers, as well as things like community health workers, among others. Next slide, please. With this in mind, local partners should always be engaging in a two-prong analysis when it comes to thinking about Title XIX claiming. This considers both the type of position you're looking at as well as the activities being performed by that position. On this slide and on the next two slides, you're going to see a series of questions that can be helpful in guiding local partners through this analysis framework in order to make informed determinations about SPMP for which they believe enhanced federal funding might apply. Next slide, please. So for the first question, local partners could ask themselves, is the position one that is considered potentially eligible as an SPMP classification? And as I think Jim mentioned just in the chat, we do have a list of classifications both in this PowerPoint and on our website of what those potentially eligible SPMP classifications are. So I would encourage you to take a look at those. But if you answer no to this question, the analysis would stop and you would go ahead and just claim the non-enhanced 50% federal funding. But if you answered yes, you'd appropriately document and then you would move forward with the next step of your analysis. Next slide, please. So if you initially determine that your classification is potentially eligible for SPMP, then you also have to ask, does the activity that that staff person is performing require their professional medical knowledge, training, and/or expertise? Again, if you answer no to this question, despite the classification being potentially eligible, they would not be eligible for enhanced funding, and you would go ahead and claim the non-enhanced 50% funding. Alternatively, if you answer yes to this question, you document appropriately, submit that to CDPH, and then maintain all documentation in the event of an audit. Next slide, please. So on this slide, as I alluded to, we have provided some examples of classifications that under federal regulations would be potentially eligible classifications for enhanced SPMP federal funding. While I won't read this directly to you, I would encourage you to reference this slide as well as the document that's on our website, which has the exact same list of classifications. Next slide, please. So it's important to note that local partners are responsible for maintaining all applicable supporting documentation that will allow CDPH, DHCS, and/or other state or federal control agencies to substantiate your approach towards Title 19 claim, either at the non-enhanced 50% or the enhanced 75% matching rate. Generally, documentation in this space is going to include some key pieces of information, which can include, but is not limited to, the things listed on this slide. Um, of important note, you're always going to want to make sure that you include the staff person's name, their position, and the Title 19 matchable program that you're looking to claim for. Again, this would be limited to those MCAH and other programs that are covered pursuant to the contract between DHCS and CDPH. You're also going to need to include the date and time span of those activities, the amount of time that you spend on those activities. It's important to include a detailed narrative description of those activities. And here we also want to make sure that we're thinking about breaking out individuals that you're serving through these various programs versus whether or not they're eligible for Medi-Cal versus not, which will be important for accurately claiming matching funds. And this will be discussed in a bit more detail here soon. Next slide, please. So with that, I will turn it over to Jim to walk us through some time study information.
The key part about these invoices is the time studies, which helps to calculate the amount of time that's eligible for FFP. There are two main factors about this, the time studied activities and also the base Medi-Cal percentage. The time studies need to include all the activities that are performed, the time that is spent by the provider with individuals with the eligible services, and the base Medi-Cal percentage, which is the percent of the population with Medi-Cal. Erica will discuss this in more detail later. In order to represent the time and eligible activities, the time study needs to include all the time during that week, which can also include any paid time off. Next slide, please. Documentation for the time studies needs to include information about the individuals with Medi-Cal so we can identify services that are provided to those that are eligible for Title 19. If the numbers that are eligible are too small, you can de-identify those when you send that to us or to CDPH, but you must keep a copy of that in case there's an audit so that we can identify the individuals. Next slide, please. All time studies must be in a format that is approved by CDPH, and they must include basic information, which you can see on this slide. I'm sure most of you are familiar since you're already completing time studies. Next slide, please. Time studies also have different function codes. Some are delegated towards SPMP, and some are delegated at the 50/50, depending on what's going on. And then there's some that are just not available for SPMP. Next slide, please. As you can see, here's the function codes that are going here, and Molly will be going through the different function codes in more detail. They're kind of split up for some that are, like I said, specific SPMP training when they're used by those provider types. And function also a specific code for paid time off as well. Next slide, please. And somebody had asked earlier about a decision tree for some of these different activities. So here's a decision tree about the scope of work and how the claimant is done. As we mentioned, this will be available on our website so that it could be accessed later for reference. Next slide, please. But now I'd like to turn it over to Molly to go through the function code examples.
I'll be going over the function code examples. Please note that these are examples only, and local partners should always conduct their own analysis and maintain appropriate documentation. Function code 1, outreach, may be used by SPMP and non-SPMP when performing activities that inform Medi-Cal eligible or potentially eligible individuals about health services covered by Medi-Cal and how to access the health programs. Some activities under this function code may include assisting a Medi-Cal eligible individual or member to review Medi-Cal related documents for medical and mental health providers that accept Medi-Cal, or developing and/or distributing a resource guide including Medi-Cal services and providers to increase access to care. Function code 2 is to be used by SPMPs when participating in medical reviews, assessing the necessity for and types of medical care associated with medical case management and case coordination activities for Medi-Cal eligible required by individual Medi-Cal members. Some activities may include consulting with a Medi-Cal provider regarding a member's health needs, including mental health and substance use disorder services, or conducting a screening and assessment to connect a Medi-Cal eligible individual or member to appropriate services to improve their health. Function code 3, SPMP interagency coordination, collaboration, and administration is a function code that is to be used by SPMPs when performing collaborative activities that involve planning and resource development with other agencies. These activities will improve the cost effectiveness of the Medi-Cal healthcare delivery system and improve availability of medical services. An example of an activity for this code would be attending interagency meetings to discuss and develop ways to reduce barriers and increase participation in Medi-Cal funded services. Function code 4 is to be used by non-SPMP for interagency collaboration and coordination. And an activity that this may be used for is when a non-SPMP collaborates to compile data reports on participant health outcomes, assessments, and statistics from implemented programs. Function code 5, program-specific administration, is to be used by all staff when performing activities that are related to the Medi-Cal program-specific administration. An example of using this function code would be maintaining and monitoring program information, such as Medi-Cal member data entry into a tracking database. Function code 6, SPMP training, is to be used only when training is provided for or by SPMPs, and only when the training activities directly relate to the SPMP's performance as specifically allowable SPMP administrative activities. An activity that may be used for this function code is providing orientation and training of a new SPMP staff regarding Title XIX FFP statutes and regulations. Function code 7 is non-SPMP training. This function code is to be used by all staff when training relates to non-SPMP allowable Medi-Cal administrative activities and to the medical care of clients. An example would be training new staff members on their responsibilities relative to Medi-Cal enrollment and referral services. Function code 8, SPMP program planning and policy development. This function code is to be used only by SPMPs and only when performing Medi-Cal program planning and policy development activities. An activity that may be used for this function code is meeting with Medi-Cal providers to increase access to services for Medi-Cal members and/or eligible individuals. Function code 9, quality management by SPMP. This function code is to be used only by SPMPs and only when performing quality management activities that benefit the Medi-Cal eligible population. Reviewing Medi-Cal member charts for quality case management to ensure appropriate follow-up and access to Medi-Cal services would be an activity where this function code is utilized. Function code 10, non-program specific general administration, may be used for activities such as attending agency meetings and non-MCAH related training such as HIPAA, health and safety, and prevention of sexual harassment. This function code is to be used by all staff when performing non-program specific administrative activities that relate to multiple functions or to no specific identifiable functions due to the general nature of the activities. Function code 11, other activities. This function code is to be used by all staff to record time performing activities which are in the scope of work but not specific to the administration of the Medi-Cal program. These activities do not qualify for Title XIX FFP. And function code 12, paid time off. This function code is to be used by all staff to record usage of paid leave, holiday, vacation, sick leave, or any other paid leave. All paid time off must be prorated between enhanced, non-enhanced, and non-claimable. And now I'll turn it back to Erica.
Thank you, Molly. So I think you've already heard us say several times today, and I will try to speak a little slower this time around. I apologize. I'm a fast speaker by nature. So Title 19 funds are only available for those costs that are associated with administrative activities that benefit Medi-Cal members. Again, such as like helping them access services or helping them to get enrolled into our program. So DHCS and CDPH both recognize that our local partners serve more than just Medi-Cal members. You all do very important work, and we very much recognize and appreciate that. So, to this end, it is very important to specifically be able to identify the exact number of members who are being served relative to all individuals served, so other members of the public. And if you can't determine the exact number, which can be difficult at times, having a sort of proxy methodology in place that is an objective, standardized, and defensible way to identify Medi-Cal members. This is often called the Medi-Cal factor or the Medi-Cal percentage. Next slide, please. Essentially, the Medi-Cal percentage is a fraction in which the numerator is the number of eligible Medi-Cal members served per activity by a local partner within a particular period of time. So, for example, a quarter. And the denominator is the total number of individuals served per MCAH program activity by the local partner within that same period of time. So again, in this example, a quarter. For more information about how to calculate the Medi-Cal percentage for MCAH programs, we would refer you to our frequently asked questions document, which has a bit more detail, and it's also available on our website, and we will drop that in the chat for ease of reference. Next slide, please. So as I mentioned earlier in today's call, documentation is a theme you'll hear a lot when we're talking about Title 19 claiming, and it is critical for local partners, CDPH and DHCS when it comes to Title 19 claiming. Ultimately, we're all in this together, and so it's important that we each take the time to review information for accuracy and document comprehensively for clarity. The more effort we put into taking the steps to document correctly on the front end will ultimately help reduce back end work and also stress in the event of an audit. To this end, when CDPH submits invoices to our department, they include a Title 19 cover letter, which is shown on this slide, and it contains key information that's necessary for our team to be able to approve invoices with confidence. Looking at the elements on this cover letter can help local partners also better understand the types of things that they should be documenting in more detail on their end. Next slide, please. Local partners should also submit their Title 19 invoices to CDPH using a standardized template, along with an attestation form, which is shown on this slide. This certifies that the local partner has performed their own due diligence in conducting an analysis of its personnel and determining which are eligible for non-enhanced versus enhanced funding. And again, you're going to want to keep this documentation on file in the event of an audit. Next slide, please. Additionally, we're always thinking about compliance monitoring and oversight, which is an essential function of all government organizations. To this end, local partners should be ensuring that they are reviewing, understanding, and complying with all state and federal funding, reporting, and auditing requirements. CDPH and DHCS, as well as state and federal oversight agencies, have the right to monitor, audit, and/or conduct on-site reviews of records maintained at the local level. So when issues are found, it's important to remember that corrective action plans and fiscal recovery plans may also be created. Additionally, it's also important to remember that inappropriate Title 19 claiming can result in DHCS having to pay back federal matching funds to CMS, which means working with CDPH to recoup those funds from local partners. At the end of the day, this is something that all of us want to and can avoid to a large extent with deliberate, thoughtful Title XIX analyses and claiming, as well as ensuring that we maintain appropriate, comprehensive documentation. Next slide, please. So on this side, you will see a list of a lot of helpful resources. We've already provided links in the chat to the DHCS website, and I would, again, particularly point you to the newly developed FAQ, and on the CDPH website, I would point you to the Fiscal Administration and Procedure Manual, which has a lot of really great details. And again, would just encourage you to take a look at that SPMP questionnaire, which has those potentially eligible classifications. And again, not an exhaustive list, but meant to serve as a tool for local partners to make informed decisions as they go through that two-prong analysis that I walked through at the beginning of today's call. Next slide, please. So recognizing that that was a whirlwind of information and that, when we went through it fairly quickly, we're happy to go back, highlight any areas of key importance, and we're also happy to now answer some of your questions. As mentioned at the beginning, we were going to start with looking at the questions in the chat. Some of those have been answered throughout the course of the presentation, and then we will open it up for verbal questions, just recognizing that we have over 300 people on today's call, which is wonderful. Would just ask that if you raise your hand, we will call on you and ask you to come off mute. If you could also introduce yourself and the organization that you're from so others hear it, that would be great. And now we would be very happy to answer your questions. So I'm going to go ahead and turn it over to Molly, who will be our facilitator for this portion.
Okay, so first question in the chat I show is, can you explain how non-SPMP staff, such as secretarial positions who directly report to an SPMP, can claim enhanced codes such as 2, 3, 6, 8, and 9? For example, a secretary taking minutes for an SPMP who is doing program planning and policy development.
Sure, so I can start, and then I can have Jim weigh in as well. And I know we also have, I believe, on this call, partners from CDPH. And since the question is specific to CDPH's function codes, I would also welcome them to weigh in. So I do just want to reiterate that, as mentioned during the call, in order to claim enhanced federal funding for staff who directly support the work of SPMPs, again, they have to be directly supervised by the SPMP, which will be evidenced by the org chart. And the work that the supporting staff is doing must be directly necessary for completion of the SPMP's professional medical responsibilities. So that is a causal link that I just want to highlight. This is one of the reasons why I think the analysis is so critical and the documentation. Title 19 claiming is an area where I do believe reasonable minds can differ. But that's one of the reasons why we need to take a strategic, organized, and objective approach to how we conduct the analysis. So again, you have to be able to articulate in your analysis how what the support staff is doing is directly necessary for the supporting the SPMP in their professional medical/clinical work, and not something more general. Otherwise, you'd be looking to claim at the non-enhanced rate. And I don't know, Jim, or if any of our CDPH partners want to specifically comment on the function codes.
Yeah, I can't speak on the function codes, but I would say as a principle, is if the person is like enabling the SPMP to perform SPMP activities, then that would be a guideline to consider.
Jim. Molly?
Let's see. Sorry, next question. How often does the NCF percentage need to be updated?
Did you say NCF? What was the acronym?
MCF, Medi-Cal factor percentage?
Right. So, and again, I don't know if we have any partners from CDPH on the call. What I would suggest is that anytime you're submitting an invoice to CDPH, what then ultimately gets translated into an invoice to our department, you should be taking steps to ensure that if you're applying the proxy methodology through the Medi-Cal factor, that it is an accurate representation of the current percentage of the Medi-Cal population that you're serving relative to your whole population. So for example, if you know that you've had like a shift one way or the other in the number of Medi-Cal members that you're serving, you should be adjusting those as you submit invoices for claiming. You want to be as tied in real time as possible for these percentages, because at the end of the day, if CMS or a federal control agency comes and does an audit, they will be looking at the point in time in which you claim the activities relative to the population that you were serving. And again, we can only claim the SPMP, or sorry, the Title 19 claiming, whether or not at the enhanced or non-enhanced rate, for either the specific population of Medi-Cal members you were serving, or using the proxy methodology for an overall percentage. And I don't know, Jim, if you want to add anything.
I'm also able to answer from CDPH. Your partners are here and present. We do the Medi-Cal factor / percentage annually with all of our local health jurisdictions each AFA season.
You.
Next question we had in the chat was they're trying to get a better understanding of when it lands as administrative tasks or in support of SPMP tasks. So they're wondering if you could please clarify.
So I think we kind of answered this question already. But to Jim's point, the way you should think about this really is the work that the directly supporting staff doing, is it in furtherance of the sort of medical or clinical aspect of the SPMP's work? If the answer to that question you believe is yes, and you can sufficiently document that, and you believe it would be defensible, I think that would be the way you should approach it. The problem with Title 19 claiming is that there are no hard and fast rules, which is why I do want to emphasize the analysis framework for which you should be approaching all of these things, and the importance of documentation. And I don't know, Jim, if you want to add anything else, or if any of our partners from CDPH who are on the call as well.
I'm happy to support. It sounds like day-to-day, and I'm Angelica Jimenez Bean, Contract Management Allocation Process Section here at CDPH. It sounds like day-to-day administrative functions would not necessarily be applicable unless, as they have defined, it is like medically necessary, supports the SMP in a way that's of nature of their medical clinical expertise, but not necessarily day-to-day administrative functions. Am I summarizing that okay? Thank you.
Perfectly summarized. Thank you.
Another question we had is, are there any specific enhanced codes for SIDS and CPSP activities?
Angelica, do you want to take that one?
Sure, and this one I would have to defer to our program folks. If there is anyone from CDPH program here at MCH available to answer specific programmatic questions. If not, what I would say is that folks should reach out to their program consultant within our division in order to request us either certain activities or to see if there is that cross flexibility within programs here at CDPH that we support.
Here real quick too. I'm Mary Boast. I'm with CDPH. In the example that was on the PowerPoint, I don't recall any specific examples for SIDS, but again, reach out to your PC. This is just a subset of examples. There may be other areas where you'd have a SIDS or a CPSP example that would apply.
Next question. If a client has private insurance, but they are eligible for Medi-Cal, can we code those to a possible code 2 for case management?
So unless CDPH happens to know the answer to that, I'd like to take that one back, and we can incorporate that into our FAQs because I don't think we address any other health coverage topics in our current FAQs. So just confirming DHCS will take that question back and we will plan to loop back with this group.
In the chat, someone asked, what about our CHWs providing translation for our SPMPs? Can they claim enhanced?
So CHWs are not an SPMP eligible classification, and they would also not fall under the supporting staff role. So those would be claimed at the non-enhanced 50%.
Are there any exemptions for rural frontier counties in regards to serving Medi-Cal only eligible clients due to limited access to care for all?
So assuming I understand the question, I think the answer is I'm not aware of any specific policies or limitations, but I don't know if our CDPH partners are.
Okay. The next question I have is for FFP objective number 2, assisting individuals on Medi-Cal to access Medi-Cal services. Is there a resource that references what is considered a Medi-Cal service?
I think Jim dropped this in the chat, but we have a list of covered services on our website, and I think Jim dropped it as well. But it would essentially be any benefit or service that's covered by the department. And again, I do want to emphasize it has to be tied to an MCAH program that is covered under the interagency agreement with CDPH. I recognize that there's many benefits and services that might be beyond those that are provided, but the Title 19 claiming that flows through this contract is limited to those subset of programs that are included in our IA. And Molly, if you could drop those in the chat, that would be helpful, I think, for folks to clarify.
Okay. And the last question I see is a Medi-Cal provider survey sent by administrative staff considered enhanced or not?
So generally speaking, surveys are going to be non-enhanced. It's not sent out. It's not a requirement of like having medical knowledge and expertise. It's just an administrative activity. So it would be a non-enhanced 50-50.
Okay, we got a couple more questions after that one. So if an MCAH, PEI, CHVP program that is leveraging Title 19, then are we considered a Medi-Cal service?
So again, it comes down to it has to be one of the programs that's covered under the interagency agreement between DHCS and CDPH, and it has to be a Medi-Cal covered service. And generally speaking, all of the services and supports that are provided through those MCAH programs are also covered Medi-Cal services. And again, I think we dropped the list in the chat, but we'll drop the list of programs covered under the IA if folks are not aware of what all of those are. I think there's like 5 or 6. And then we also shared a link to our covered Medi-Cal benefits in the chat as well.
Okay, I think the last question from the chat, and then we can go to the people. What is best practice for defensible documentation of these activities? For CHVP, are notes on exact duties completed necessary in addition to staff completing time studies?
Yeah, so that's a great question. So in terms of best practice, when it comes to Title 19 claiming, I I can't emphasize enough that less is not more. So my recommendation would be to maintain comprehensive, detailed documentation that includes both the time studies, which do certainly convey important information, but also additional supporting documentation that clearly articulates in an understandable way what the staff are doing, particularly if you're attempting to claim SPMP enhanced claiming. In the event of an audit, it is much easier to have done the front end work to prepare these materials to turn over to either DHCS, CDPH, or a federal or state control agency than it is to try to create them from whole cloth on the back end. So my recommendation would be to include those types of narrative descriptions as part of your overall file that you would have available to produce in the event of an audit. And just to build on that, on our Title XIX Claiming Toolkit website, we do include some examples of prior audits that have occurred in this space from the Federal Office of Management and Budgets. If you have a chance, I would encourage you to go look at those audits around Title XIX claiming. There's also some board decisions. They'll give you a really good sense of the types of things that might be looked at in an audit, which could also help you decide how you want to structure your documentation. Again, there's a whole bunch of things in there, but they could also be a really good resource for understanding what might be looked for in the event of an audit.
So now if I'll go to the individuals at the presentation, I see that Jessica Ferrer has a question.
Hi, thank you. We're contracting with a public health nurse to complete home visiting services, and my question is if this subcontractor, an individual being paid through contract rather than payroll, is eligible for Title XIX drawdown. Thank you.
Jessica, it's an excellent question. So the short answer to your question is yes, subcontractors can be eligible for Title XIX claiming. All of the same rules and requirements would apply. Additionally, I would just recommend that for supporting documentation, you're going to want to make sure that you include evidence of that subcontractual relationship that would, again, be available in the event of an audit. And all the things we talked about documentation would also apply here. I hope that's helpful.
I see that Kate was with. Sorry if I cannot pronounce your last name. Kate has a question. Grozweski, thank you.
Can you guys hear me?
Yes.
Can you guys hear? Oh, okay,
Yes.
sorry. I'm losing my voice. I apologize. But just to follow up with Jessica, I just want to make sure. So contracted SPMPs can also pull down the 75% match? Because it was always my understanding it was only the 50-50 they were allowed to do.
Yeah, so we had this question come up. I think maybe our partners from GIAC actually raised it for our consideration. So the way it basically works is when you're a subcontracted entity, and again, let me just preface everything I'm about to say, which is this is not legal advice, and you should definitely consult your internal legal counsel for, double checking all of this. But generally speaking, if you have a subcontracted relationship, those staff persons are acting on behalf and providing services to our members in the same way that someone who worked on your payroll would. So all of the same rules and requirements would apply. You would have an established employer-employee relationship with that subcontractor, and it would be evidenced by whatever contract you have in place with them. And again, I would strongly emphasize that documentation is very important, particularly because when you have that second-degree subcontractual relationship, it could be an area where there's increased scrutiny in the event of an audit. So I hope that's helpful.
No, definitely. Thank you. Thank you very much.
In the chat, someone asked, what about time spent by an SPMP to assist a parent caregiver in completing a developmental screener? Is that considered enhanced time or non-enhanced?
Sure. So I would just bring us back to our two-prong analysis framework. So if you look at the first prong, you would have an SPMP eligible classification. So you'd move on to the second prong. And then you would just have to ask yourself, is what the SPMP doing? Is it something that requires their professional medical knowledge, training, and or expertise? I would suggest that helping to fill out a survey may not require that, but again, you have to go through the analysis. In the short answer of this presentation, I would suggest that assisting with filling out a questionnaire is not something that requires particular medical knowledge, skills, and or expertise. And so it's something that, another person on the staff could do just as easily. But if again, you document, you make the argument, it's on the local county partners to do that two-prong analysis, like I mentioned, and that's why documentation is absolutely critical.
Okay, I see that Paula has a question for you.
A comment on that last question. So for those types of ASQs in where a staff could be trained to actually be working with the mom on the certain activities that would allow the child to improve in their developmental stage in the different areas, I would imagine that you have to have specific training for that. That just screening would not qualify, but if you're actually doing an hour and a half visit with the mom and you're on the floor helping that baby, I would imagine that yes, you can claim SPMP.
Yes, absolutely. I would agree. So in that analysis framework, I keep bringing it back to it, but yeah, if there's basically a clinical knowledge or expertise that someone has to have to be able to sort of direct the parent or guardian through that process for their child, then yes, I would agree that would. And again, you would go through the analysis, you would put the documentation in the file, and then you would roll that up into your time studies and things that you submit to substantiate the invoices.
We have a question in the chat. How might we balance the work with a comprehensive documentation best? Any best templates or samples you can provide?
Sure. So on our website, we do have an SPMP questionnaire that local partners are welcome to use to help them with the analysis framework, and it also can be included as part of the documentation. We can drop it in the chat, but essentially it's a fillable form PDF that's available for you all to use. It includes a lot of what we were talking about today, so the position, the reporting structure, opportunities to describe the specific duties, and examples of how it requires use of medical knowledge, skills, and expertise. And it goes through that full sort of analysis framework. That is a tool that's available to all of our local partners, and we would encourage you to use that. Then you would include things along with this like organizational charts and duty statements, which I think you're all very familiar with, along with your time studies. So I think it's really a package of supporting documentation. In terms of like a template for the actual documentation itself, we don't have anything per se, but this questionnaire I think is a very good resource and a starting point for that framework analysis.
Okay, we have a question. If we are working to link clients to the new CalAIM Medi-Cal services like ECM, community supports, housing, etc., non-medical but covered by Medi-Cal, is that a claimable activity?
Yeah, so this would fall under that sort of second piece. So it's either providing covered services to Medi-Cal members or assisting Medi-Cal members with connecting to Medi-Cal services. So I know I focused on enrollment, but it can also be helping navigate Medi-Cal members into our various programs and benefits. So yes, that is something that would also be sort of included under this umbrella, under that enrollment slash navigating them to our programs and benefits aspect.
So that's all the questions that I can see in the chat, and I don't see that anyone's raising their hand, so. Looks like Jack has a question.
Hi there, Jack Anderson with CHIAC. Just wanted to take a moment to express our gratitude to DHCS and CDPH colleagues for hosting today's training. I know, CHIAC has been working closely with both departments very, over the last several years on Title 19. And so I do just want to express our appreciation to you all for hosting today's training, and look forward to, additional resources to come to support our local health departments in maximizing this funding source. So thanks.
Thank you, Jack. We really appreciate the partnership.
Looks like there's a question from Jared. Fine.
Hello. Has the department put a ceiling on how much FFP California is interested in applying for from CMS?
Jared, no. So there's no per se cap on services. It's tied to the non-federal share that either we or our county partners put up. We're a public entitlement program, and so obviously we provide benefits and services to our members based upon medical necessity. And so, if there's a non-federal share, we put that forward to claim the applicable federal match.
That's a wonderful answer. Thank you so much.
And I dropped it in the chat, but we do have a dedicated email inbox for Title 19 claiming questions. So if you don't think of questions on today's call, we are here at the department to support all of our local county partners relative to claiming. So please feel free to drop us questions at that Title 19 claiming BD at DHCS inbox. And again, that is in the chat.
We did have another question come up. If they asked, are we able to use enhanced function codes for clients who do not yet have Medi-Cal but are Medi-Cal eligible?
So would welcome CDPH to weigh in, but I would just remind folks that the Title 19 matching funds are available for both active Medi-Cal members who are seeking Medi-Cal covered benefits and services through the MCAH programs, but they are also eligible to county partners who assist Medi-Cal members in getting enrolled. So being actively enrolled in Medi-Cal is not a per se requirement of getting Title 19 funds, because we know that part of it can be also getting members into our program and or helping them access services under our program.
I would also like to add that Medi-Cal eligible is like a term of art that basically means the person has eligibility, is covered by Medi-Cal, and what Erica is describing about efforts to help people enroll in a Medi-Cal. But if you just say someone's eligible, but they're not enrolled, and you're not actively trying them to enroll, then they're not a Cal member and you cannot claim for them. But if you do your Medi-Cal percentage, that'll cover that issue.
And I did see an easy question in the chat. So these slides are, this training has been recorded, and so the slides will be posted on our webpage, I think by the 21st. So a week from today, for those of you who would like to review them, listen to the recording, pause me, slow me down, stop me because I talk so fast. You can do that, and you can also share it with folks who weren't able to attend today's call.
I don't see any more questions at this time, so.
I do just want to put out an offer to our CHIAC partners as well as our local county partners on today's call. I know you all asked around sort of best practices and resources that might be helpful in navigating the documentation aspect of Title 19 claiming. So I know I mentioned the SPMP questionnaire that's available to you all. But if there are additional sort of resources or templates that you think might be helpful, we are open to working with CHIAC to figure out how we might create those materials. So please, please, please feel free to send any suggestions to our Title 19 claiming inbox. And then to our CHIAC partners, if you all want to talk to your respective members and think about things that might be helpful, we would love to have those conversations with you all as well. Obviously, the goal here is to be as helpful as possible for our county partners around Title 19 claiming. Okay. So I'm not seeing any additional questions in the chat, and there's no hands raised. So I do want to be respectful of everyone's time. It's been a pleasure today to deliver this training. The department's plan, just for awareness, is to try to issue this training, an updated version of it, of course, if applicable, on an annual basis. The recording will live into perpetuity on our website for your reference. And again, if you have questions, please submit them to our Title 19 training box. Again, on behalf of the department, as well as our partners at CDPH, we very much appreciate your time and participation today. Thank you so much, everyone.